Hello, everybody. On behalf of ESG, I would welcome you to this webinar dedicated to pancreatic cystic lesions. So how to optimize the diagnosis and the therapeutic role of EUS. So I want also to welcome Mariachiara Petrone and Pierre Deprez. Welcome to both of you. You have to know that you have the opportunity to view, of course, high quality presentation on endoscopy topics with experts in endoscopy, and also to interact with speakers. And at the end of the webinar, we will have a place for Q&A, and you can already put all your questions in the Q&A box, and you can also receive CME credits. So next slide. And this evening, you will receive an email with a link to complete the CCMA survey in order to receive your CMA credit and certificate. And what is very important, you have to know that the survey will close on March 20. So don't save the date and try to answer before March 20. So now I think I will just introduce Maria Petrone. Everyone knows Maria, and she will speak about a role for expertise in the role of EUS in diagnosis of pancreatic cystic lesions. So Maria, it's up to you now.
So hello, everybody. I'm really happy to be here to share with you this very important topic. I would like to start with this first slide. This is what typically happens in our daily practice. A patient comes to our attention because of an incidental diagnosis, and this is a pancreatic cystic lesions. So we know that today this diagnosis represents a common diagnosis, very common diagnosis in the practice of gastroenterologists, and the main reason for this increased incidence is the widespread use of CT and MRI imaging, which have led to the detection of these incidental findings. But if we look at this meta-analysis about the prevalence of incidental diagnosis of pancreatic cystic lesion, we see that the prevalence is quite high. But the problem is that the evidence is very low. I mean, if we look for IPMN in PubMed research, we obtain about 2,000 papers, but we have only 2 randomized controlled trials, meaning that probably no other common disorder is so non-evidence-based. However, after this new diagnosis, a clinical dilemma begins for the physicians, because the question is, what kind of cyst is it? We know that pancreatic cystic lesions can be generally divided into 2 main groups, which differ greatly in their malignant potential: mucinous cystic lesion that can be precursor of pancreatic cancer, and non-mucinous lesions that are benign lesions with indolent behavior. Moreover, we have to remember that within the mucinous group, the risk of degeneration varies greatly. So the management will be different, of course, and usually the patient is very worried about this new diagnosis. In this study, patients under surveillance for IPMN were compared to patients who underwent surgery for the same disease, and the first group of patients under surveillance reported an increased score for symptoms such as depression or anxiety. So the quality of life of this patient is for sure reduction. And probably also the physician should be a little bit stressed, because we know that we make mistakes. In the last decade, several surgical series have been published, and we know that there are patients who undergo surgery for a benign lesions who were presumed to be pre-malignant or malignant lesions. So our goal is to identify premalignant or malignant lesion that will benefit from surgical resection, and also to avoid unnecessary surveillance in benign cysts. And the rule of EUS following radiological imaging is to evaluate cysts that are indeterminate or have risk features. And the question that we should have always in mind is if the EUS may change management. So 3 main guidelines on the management of pancreatic cystic lesion exist. The guidelines of International Association of Pancreatology, the American Guidelines Association, and the European evidence-based guidelines. And these guidelines tend to be consistent regarding the in indication of surgery, while they diverge about the indication for surveillance and also on whom to select for endoscopic ultrasound. The international guidelines recommends EUS for patients with any one of these clinical or radiological features that you can see. AGA suggests EUS only for cysts with 2 or more high-risk features. And for the European guidelines, EUS is considered just as an adjunct to radiology during surveillance. What we know very well is that EUS morphology is not enough to differentiate mucinous from non-mucinous cystic lesions. This is a very old study, but is a landmark study in this topic, in which patients, EUS morphologies was compared with histology. And as you can see, the diagnostic accuracy was very low, only 51%. Moreover, inter-observer agreement between endosonographers is poor, not only for differentiating neoplastics versus non-neoplastic lesions, but also in describing EUS features. So there have been many papers evaluating imaging findings related to malignant progression of mucinous cystic lesion. This meta-analysis of about cyst features and risk of malignancy in IPMN show that cyst sites, the dilation of the pancreatic duct, and the presence of mural nodule are independent risk factor associated with the malignant progression. But more recently, has been shown that among these features, the presence of mural nodule is probably the strongest predictor of malignancy. So if we have a suspicion for degeneration, if there is a nodule, a combined approach with contrast enhanced EUS should be required, since we can obtain more information about microvascularization of the tissue. This is an example. We have 2 small cysts of pancreatic body, and we can see a nodule in this case, but after contrast injection, we are sure that this is not a nodule, but is a vascular material, and we can easily say that this kind of cyst has no sign of malignancy. And this is another case, completely different. We have a larger cyst with a mural nodule, and in this case, after contrast injection, we can describe an enhancement of these nodules. So this is for sure a predictor of malignancy. So this is a meta-analysis. The aim was to evaluate the performance of contrast-enhanced EUS for the identification of high-grade dysplasia or carcinoma among mural nodules. And the results are impressive, since the sensitivity is very high, 97%, also the specificity, with a diagnostic accuracy of 96%. And also very important is the negative predicted value that was close to 98%, meaning that the absence of contrast allow us to exclude a sign of malignancy. Of course, we can add more diagnostic information with fine needle aspiration and the analysis of cyst fluid. We can do a macroscopic evaluation just with the color and the viscosity of the fluid, and then we can use fluid for cytology, for markers, for molecular analysis, and also we can use new tools for improve the diagnostic accuracy. What about fluid cytology? This old meta-analysis, including 18 studies, show that the specificity of cytology was very high, 93%, but the sensitivity was low, only 54%. So the problem is related to the fact that there are few cells in cyst fluid that are not sufficient for diagnosis. So the specificity is high, but sensitivity is low. Of course, the diagnostic yield improves if there is a solid component inside the cyst, but this is a different situation. What about the fluids for intracystic CEA? Fluid CEA is a marker of mucin production, and is secreted from luminal surface of cells of mucinous cyst. It is a reliable marker for differentiating mucinous versus non-mucinous cystic lesion. It is not predictive of malignancy, and it has a high specificity of 93%, but a low sensitivity. And for sure, it has been the most available marker used during the last 2 decades, I would say. And the guidelines continue to recommend a cutoff value of 192 for differentiating mucinous versus non-mucinous lesion. Low levels of intracystic glucose have been shown to help to differentiate mucinous from non-mucinous lesions. The first report has been published 10 years ago, and since then we have many studies about the diagnostic accuracy. And this is a meta-analysis including 600 lesions, and the aim was to evaluate the diagnostic yield of intracystic glucose alone compared to CEA. And as you can see, the sensitivity was significantly higher, 91% compared to sensitivity of CEA. No difference in terms of specificity, but the diagnostic accuracy was significantly higher. And the combined test did not improve the diagnostic accuracy. And this is another study recently published that confirms the results of the previous meta-analysis. However, I would like to show you because the gold standard was in this study was histology for all the patients included. So the aim was to compare again glucose and CEA concentration in differentiating mucinous lesion versus non-mucinous one. And again, the sensitivity was significantly higher, 95% compared to CEA. Also, no difference in sensitivity. And interesting is the negative predictive value that was again significantly higher if compared with CEA value, and also the diagnostic accuracy. So in other words, intracystic glucose seems to be superior to CEA alone in differentiating mucinous cystic lesions. And what about molecular analysis? We know that in mucinous cystic lesion, the most frequent genetic alteration is an oncogenic KRAS mutation. KRAS and GNAS mutations are commonly seen. And we know that non-mucinous cystic lesions do not have this kind of mutations. And this is a meta-analysis recently published to evaluate the diagnostic performance of KRAS and GNAS mutation in pancreatic cyst for diagnosis of IPMN and mucinous cystic lesions. And again, there are very good results in terms of sensitivity specificity and also diagnostic accuracy. The guidelines feel that the use of molecular markers is still investigational and not ready for routine clinical use. What about these new tools? So this both confocal endomicroscopy and microforceps biopsy may improve diagnosis of pancreatic cyst. Both require passing the confocal probe and the microforceps through a nitrogen gauge needle, which limits the size and location of the cyst eligible for these techniques. Many studies have been published about sensitivity and diagnostic accuracy. About endomicroscopy, sensitivity for mucinous cysts range from 66 to 90% with a complication that is not negligible, complication rate that is not negligible. And about through the needle biopsy, recently has been published this meta-analysis, including about 500 patients, and sensitivity and specificity for mucinous cysts were very high, 89% and 95%. And also in this case, the adverse events rate was not so low. However, current guidelines do not endorse the use of these techniques because we need for sure more large prospective trial, and we need that these results have to be validated by other groups. So this is an interesting paper. It's a retrospective study that described the experience of pancreatic surgery at Massachusetts Hospital with resected pancreatic cyst during the last 3 decades, so from 1990 until 2020. 1,300 patients were identified, and 57% of these cysts were incidentally discovered. And as you can see, the concordance between preoperative diagnosis and final histological diagnosis increased by decade from 45% to 80%. And we can see also that the preoperative approach has changed over time. I mean, in the beginning, CT scan was almost universal, but then there was a progression in the use of endoscopic ultrasound in the last decade associated with cytology and NGS. Of course, a progress in correctly identified cysts that required resection has been made. However, in this series, 10% of patients underwent surgery for the benign lesions again. So there is still need to improve risk stratification of patients. And finally, I would like to show you this. This paper is a multi-center. Sorry. Is a multi-center international study where the authors described the development of a prediction model that does not focus on identifying IPMN at high risk of malignancy, but on those at low risk of progression. And it is based on patients and cyst features that can be assessed at the time of diagnosis. And predicts the 3 years and 5 years risk of developing worrisome feature or high risk stigmata. So the idea is to decrease the weight of surveillance on patients and also to better optimize the surveillance interval. So the model was, the final model include 5 predictors for malignancy that were the disease sites, the multifocality, the history of extrapancreatic malignancy, the history of acute pancreatitis, and also history of smoke. And after internal validation, the model seems to have good discriminative ability. And the same prediction model has been validated by another international external court, reaching the same results. So probably that is a web application seems to be something that we could start using to identify IPMN at lower risk of progression that may allow us for a reduced intensity of surveillance. So in conclusion, we know that accurate diagnosis and classification of pancreatic lesion continues to remain a challenge for physicians. The role of EUS and FNA are very important in classification and identification of the cyst, mainly for contrast enhanced and for probably intracystic glucose. And even if the guidelines, of course, are very useful for managing these patients, we have to remember that the approach to each patient should be individualized, considering the comorbidities, the clinical status, and the personal preference of the patients. Thank you, Marc.
Okay, thank you, Maria, for this excellent lecture, and very clear, because it's difficult to be very clear with a so large topic. So, of course, we will have a question and answer at the end of both presentations, but I just want to underline a short comment. I'm very surprised because we have a lot of components of the fluid analysis which are very accurate, with about 90% of diagnostic accuracy. And finally, we are still doubtful about a lot of pancreatic cystic lesions. So do you do at all the time, all the fluid analysis with cytology, CEA, glucose, and mutations? What do you do? Do you do everything or only someone?
We do CA glucose even when possible. So if we have a cyst of 1 centimeter and a half, we always do FNA for CA, cytology, and the glucose.
Okay, because you know, when I saw your presentation, I looked to the addition of glucose and CA, and the addition dropped down the sensitivity and the predictive negative and positive value. So do you associate always glucose and the CA?
We always do both, because sometimes you have CA between 5 and 190, so you don't know if that patient has a mucinous cystic or not. And in that case, glucose for sure can be useful for differentiating. So now, yes, we perform again both.
Okay, so I think at the end of the both presentation, we will have time to discuss in detail about the fluid analysis, but also with confocal laser and through the needle biopsy. And now I think it's time to thank you again, Maria, and to give the place to Pierre. So Pierre, could you present Achieving More with Therapeutic EUS? Thank you very much, Pierre.
Yeah, thank you, Marc. You see my disclosures here. Indeed, it was difficult to cover in one session all the different aspects of diagnosis and treatment for pancreatic cysts. So I think Maria did a great job summarizing what can be practically done now to differentiate those lesions. I will only focus on two aspects. One will be the ablation of cystic neoplasm and the treatment of pseudocysts. So I'm not going to talk about abscesses or wounds or necrotic collections, because that's, I think, a different topic. So we have to save time. Concerning cystic neoplasm, there have been recently several studies showing that it may be performed quite safely, mostly with the indications of bridge to surgery, or in patients that are inoperable, or patients refusing surgery, with two main techniques: radiofrequency ablation and ethanol or paclitaxel injection. And you see the papers from Marc Barthet's groups, with a recent paper showing a long-term outcome, and I will only focus on the cystic lesions. the papers from Korea and a paper from that was published in Gastroenterology, one of the only randomized controlled trials that's available. Concerning radiofrequency ablation, this is a video coming from Marc Barthet's group. I think it's a very nice video, beautiful images, and you see this unilocular cyst between 2 and 3 centimeter diameter with a lesion, a nodule seen on the opposite wall. And you see the technique of puncture. Well, I would not puncture through the cyst, I will keep in the cyst, of course, but the technique for radiofrequency ablation is then to suck the fluid and then to repuncture with the radiofrequency ablation probe, and then you have a higher chance to ablate the full wall of the cyst. And you see here the bubbles. I think Marc is using 50 watts, and then you look at the bubbles and the impedance not going over 100 to 500 ohms before stopping the application of the radiofrequency. You can see here a video from the Korean paper, the same kind of lesion, unilocular with a nodule in the middle, and you see that insert the needle. And then in case of alcohol or injection of chemo agents, you have to aspirate the fluid to measure the quantity you aspirate and then to replace with alcohol, 99% ethanol with the same volume. And then you aspirate, you re-inject for about 3 to 5 minutes to be sure that there has been enough contact between ethanol and the, you see here the fluid after the ethanol lavage. And then they inject the same volume of paclitaxel, or in some studies, gemcitabine. And you see here, large study, 164 patients, 150 evaluated for treatment response, and you see complete cyst resolution in the vast majority of these patients, and no achievement of resolution in 44 of these patients, and then some of them were surveyed and some of them were sent for surgery. The results of these papers, first the results of RF ablation, these are the long-term results just published by Marc Barthet's group last year in EIO. You see the kind of cyst that treated. This is, I guess, a bit more complicated lesion because it's an IPMN with multiple cysts, and I guess it's not easy to ablate everything there. And you see that at 3 years, in the 17 patients treated, size of the cyst were between 9 and 60 millimeter. You see that there was disappearance of the cyst in 6 cases, 40%, significant response in 26, and disappearance of the nodules in all the lesions where there was a mural nodule visible. So this is quite encouraging, of course. Concerning the ablation with ethanol, long-term results, you see the patients in which the resolution was achieved at the short term, 98 remained in remission at 6 years follow-up, and the best predictive factors for complete resolution were unilocular and of course small cyst size cysts. To show you the paper published in Gastroenterology, which is quite interesting, they compared in 46 patients, 21 who received saline lavage and then paclitaxel and gemcitabine infusion. That's 14 patients, 21 patients, and 18 received ethanol, 80% here, and infusion after the lavage with ethanol with paclitaxel and gemcitabine. And you see that similar complete response rates, but more complications in the ethanol, 80%. You see 6% pancreatitis needing hospitalization. So the conclusion of this study is that if you use chemotherapy agents, you might not use ethanol, of course. Be aware that ethanol should only be injected in non-communicated cysts with main pancreatic duct, because otherwise there is a risk, of course, of ethanol going into the main pancreatic duct. I found also an interesting study just published this year showing that in patients that were sent for surgery when there was no remission, you see that half of these cases had still ovarian type stroma in the wall. So when you don't see any disappearance of the cyst, there is of course a risk that there is remaining tissue in the wall, and you have to be concerned about this, of course. So to conclude this chapter of this lecture, significant response is about 60 to 70% of patients, complete disappearance of the mural nodules, but there are still challenges and limitations in assessing the value of EUS ablation in these cysts. And also there is a risk, don't forget that there's always a risk of distant pancreatic adenocarcinoma, and of course you have to follow those patients during follow-up. And I think the DART criteria to putting those IPMN patients at risk for evolution and neoplasia have to be well taken into concern when you follow those patients. So the recent guidelines do recommend that EUS-guided cyst lavage or RFA ablation for IPMN or mucinous pancreatic cyst should not currently be performed outside of a dedicated investigative protocol. So please don't start to do this on your patients without a proper study. Concerning now pseudocysts, the second part of my talk, we know for many years now that EUS is a quite effective way to treat these pseudocysts. Compared with surgery, there is a decreased cost, a decrease of hospital stay, and of course nobody would do pure endoscopic drainage even in bulging collections because the success rate with EUS is much higher, and also it's much safer because you can control any presence of intervening vessel. So that's a point that's known for a long time. So I went through the three main guidelines published on treatment of pseudocysts, mainly in the context of chronic pancreatitis, of course, because most collections after acute pancreatitis may either resolve alone or associated with wounds, and that's another topic, I think. So you see here the international consensus published by the European Pancreatic Club, American Pancreatic Club, Asian Pancreatic Club, and there are only 4 statements about pseudocysts. And you see that pseudocyst causing symptoms should be treated, but they advise either EUS or surgical treatment. You see the statement 5.3 about asymptomatic and uncomplicated pancreatic pseudocysts of more than 5 centimeters in diameter that do not resolve within 6 weeks after the attack of chronic pancreatitis or acute pancreatitis. They may be treated by a transmural drainage. And you see that most of the guidelines, they have a statement on the asymptomatic but not resolving collections after pancreatitis, even in the context of chronic pancreatitis. And all guidelines mention that in case of a suspected neoplastic cystic lesions, diagnosis should be done first before treatment. And I would like to emphasize this by a clinical case. And I would like you to participate to the case here. There will be three polls that will be submitted to you, and we will look at your participation here. Young lady, 35 years old, so she has recurrent pancreatitis for many years, and she came to me at some point because of a cystic lesion in the tail of the pancreas. And as you may notice, she has a pancreas divisum, and she has a collection in the tail of the pancreas. Most of her pain attacks were epigastric, so it was difficult to know if it was due to pancreas divisum or maybe to the collections. And you see the different images in this case. So I went for diagnosis and treatment at the same time. So I treated pancreas divisum first, and then I went to EUS, and you see the EUS images of this cystic lesion. You see that there is a contrast, and there is some uptake of the contrast in the wall. So let you imagine what this could be. And then I performed, in my practice, I usually performed aspiration of the fluid first, and then I take the fluid for CA and now glucose and cytology, and sometimes NGS in the difficult cases where patients could be sent for surgery. And then I use a needle to go through the wall a little bit to get more tissue for cytology. I usually don't use a microforceps at the first attempt for diagnosis because you know the increased risk of bleeding and pancreatitis. So I would like to ask you if you would have considered puncture and sampling in this case. And the 4 answers I suggest to you is no, surgery is advised. I would say pancreatectomy, partial pancreatectomy and splenectomy maybe, or laparoscopic pancreatectomy. No, I would perform ERCP for drainage, or we try to put stents close to the cyst. Yes, to differentiate mucinous cystadenoma from a pseudocyst. Yes, to perform a cyst gastrostomy, and I would place a stent in the cyst after puncture. I did not put here ablation because we really need diagnosis before going for any ablation attempt. So 4% would not puncture because surgery is advised. Some would go for ERCP, and yes, most of you would puncture. You see, we have a lot of answers here, 245. And 19 of you would perform a cyst gastrostomy. So I think this was one of the reasons to present this case, because this is a really an important question if we go for drainage in such a case. So in fact, as you see, it was there was a pancreativism. EUS may be in favor of maybe mucinous or pseudocyst, difficult to say, or maybe not the lesion. Cyto was not contributive. Biochemistry showed CEA 140, so not reaching the cutoff of 192. Lipase were elevated. At that time, that was, I think, 10 years ago, there was no glucose testing, but of course now we do it. And KRAS was negative. We did KRAS in some of these lesions. So the next slide. So what would be your diagnosis now based on biochemistry and on the EUS images? Would you think it's a pseudocyst and then you might go for drainage? Do you think these are compatible with a mucinous lesion or IPMN or a solid pseudopapillary neoplasm or lymphangioma? What would be your best guess or diagnosis? You have the MRI, you have the CT, you have the EUS pictures, and you have the biochemistry. Unfortunately, there is no result from cytology, but that's the case in usually about 50 to 60% of those cases. Pseudocyst 67%, mucinous 10%, IPMN 18%, SPN 4, and lymphangioma. So most of you are in favor of the pseudocyst. I think indeed the wall was thick with a lot of debris inside the lesion. Then of course, then the next step is to take the decision or not to drain it or to finalize your diagnosis. So I think I have my last question here. I have to take control again. So we are still slightly in doubt on the diagnosis. So how could we improve the diagnosis? Should we repeat EUS after a couple of weeks or months? Should we do more molecular testing? Because we know that now with NGS, we may be more, we have a better testing with JNAS and other tests. We could go for more forceps or wall biopsy or a confocal laser endomicroscopy, or we could send the patient for surgery. So what would be your option in such a case? You see a lady, 35, recurrent pancreatitis. So most of you would go for repeat EUS, more molecular testing, and whole biopsy. Well, I think all these are, I think, good options because the cyst is not very big. It's about 3 centimeters, so we have time before taking the decision for surgery. The adjunct techniques may be helpful in the diagnosis. Well, in fact, it's always a difficult decision when you have a patient like this in your outpatient clinic. And I decided to go for surgery, and we took the lesion out doing a distal pancreatectomy, and it was indeed a mucinous neoplasm. This was a discussion that was taken with the patient. In fact, she did not improve much with pancreas divisum treatment. And yes, I was in doubt. And I think if you are in doubt with a patient, a young patient, you should not hesitate to send her for surgery, although the lesion was not more than 4 centimeters and there was no sign of malignancy. But you should not wait, of course, the sign of malignancy to suggest surgery. So let's go back to the 2 last guidelines published during this last year. And this one is from the UEG by the group, a well-known group of experts. And the first recommendation about pseudocysts is that you should do endotherapy for chronic pseudocysts whenever possible. And if transmural is elected, it should be performed under EUS guidance. Several double pigtail stents should be placed, or self-expandable or LAMS, maybe in case of solid debris. And these should be left in place until cyst resolution with a minimum duration of 2 months stenting. The second statement is about the uncomplicated chronic pseudocyst for which the treatment is indicated that they are within endoscopic reach. Here they focus on transpapillary drainage that is to be preferred over transmural drainage for the small ones communicating with the main pancreatic duct in the head or body of the pancreas. So really this is important because if you have a pseudocyst in the tail of the pancreas, you should not go for transpapillary approach because it's very difficult to drain this cyst with a transpapillary approach. The last statement from the UEG: when should asymptomatic pseudocyst be treated? So in fact, here there is no clinical indication for this. They state that, you see, it's a grade 2C with strong agreement. Pseudocysts that have reached a size of more than 5 centimeters in diameter and which do not resolve within 3 to 6 months should be treated. So this is a strong agreement. And I think this is something we see from time to time is a decision, do we have to treat asymptomatic cysts? And we can find almost the same guidelines in the European guidelines published in 2019. ESG recommends treating chronic pancreatitis-related pseudocysts if they are symptomatic, of course, or present with complication. That's easy. We know that 1/3 of chronic pancreatitis patients will develop these lesions. They should be differentiated from cystic neoplasms, such as potentially malignant mucinous neoplasm. Very important. And there are 2 routes that you can use following the next recommendations, or using, in some cases, the combination of the 2 routes. They recommend endoscopic drainage over percutaneous drainage or surgical treatment for uncomplicated pseudocysts that are within endoscopic reach. You see strong recommendation, moderate quality of the evidence. And they suggest transpapillary drainage, again, for the small ones that are connected to the main pancreatic duct in the head or body of the pancreas. You see that's the same than the UEG guidelines. And if transmural drainage is performed, the addition of transpapillary drainage seems to add no benefits. So I think this is also an important question. There are many people ask me, should we go for transpapillary drainage to improve the results? That's not necessary, except of course if there is a stricture or pancreatic duct obstruction. And then about technical aspects, double pigtail stents are preferred, and fully covered or LAMS can be considered if the disconnected pancreatic duct syndrome has been excluded. Of course, because in this case, you should only place plastic stents, or if you place a lamps, you should replace it by a plastic stent as soon as possible. And also about the timing of drainage, you should leave the stents at least 6 weeks, because there are studies showing that if you remove the stents too quickly, less than 2 months, there is a high risk for recurrence. And then I tried to find a good guideline about lamps and plastic stents. My practice in a non-complicated pseudocyst is to prefer plastic stents. And I think this is still reasonable because there are several papers and meta-analyses that do not support the role for lamps in patients with uncomplicated pancreatic pseudocyst. But I think this is still quite debated. And even in the groups that advise plastic stents for a long time, well, even these groups, I was surprised to see from the Orlando group from Shaim Varadarajoulou that also has always been advising plastic stents for uncomplicated cysts. Well, you see that in fact in pseudocysts, if you look to the right part of this panel, you see for pseudocysts, they're placing lamps for all collections now, with a very good success. And they only use plastic stents when there is an obstruction duct and a risk for disconnected pancreatic tail syndrome. So you see they have changed also their policy in the drainage of connections. But I think in Europe, plastic stents are still preferred and they are quite safe for uncomplicated cysts. So I'm not speaking about ones here. So my conclusions are quite simple, in fact. EUS cyst ablation with radiofrequency, ethanol, or chemo agents should not be used in clinical practice. And maybe we will see that in the future, but we need more studies about the safety and also to have precise indication for this, because in some of these studies, the cysts were of undeterminate diagnosis before they were ablated. So of course, if you ablate a completely benign cyst, the remission will be better than if you do it in a large mucinous lesion or IPMN with multilocal cyst. Concerning pseudocysts, there are now several guidelines. I think the indications are well defined. The indications for transmural or transpapillar routes are the same in the different guidelines published over the world now. You understood that EUS is essential for management, but you have to consider Percodins and other approaches for some of these lesions, sometimes, especially in acute pancreatitis. You should be aware of cystic neoplasm in the setting of pancreatitis. I think the case I showed you was a good example that you have also to have a good clinical sense of these patients and choose the best solution for them. And about lamps versus plastic stents for pseudocysts, in my practice, I still use plastic stents for uncomplicated pseudocysts, but the issue is still debated and we will see more paper and more meta-analysis about this topic. Thank you for your attention.
Okay, thank you very much, Pierre, because it was really challenging to speak about pancreatic cystic neoplasm and also about pancreatic pseudocyst. So you did a very clear presentation, very interactive and very well illustrated. So now we have 10 minutes to move to the question. Maybe I will try to alternate between Maria and Pierre. So Pierre, the first question is for pancreatic cystic neoplasm. Are you afraid to inject some alcohol inside the cyst, especially when it is IPMN, due to the communication between IPMN cyst and the main pancreatic duct?
But my first problem, and I want to do this for IPMN, is that sometimes the fluid is quite viscous. So it's not always easy to aspirate viscous fluid completely or almost completely from these lesions. And indeed, if there is a large communication or visible communication with the main pancreatic duct, I would not do alcohol injection. Maybe we could use only paclitaxel, or maybe we could use radiofrequency ablation, because then you will not transmit the energy to the main pancreatic duct, but I would refrain from doing this when there is communication indeed.
Okay, now I have a question about RFN and alcohol in multiple cysts. Do you treat all the cysts or only some cysts? How do you proceed to perform pancreatic cyst neoplasm treatment? You select only some cysts?
In my practice, I only did that occasionally, so we have no controlled trial going on in cysts. I think you are the best experts to give your opinion about this. I think alcohol injection in the pancreas is always a risky procedure. We have done that for not only cysts, but for neuroendocrine tumors, and there are associated complications. So I would be very careful doing this. But please, Marc, give you your opinion.
I will try to give my advice. I do only RFA, no alcohol injection, because I'm afraid about pancreatitis due to the communication between IPMN and main pancreatic duct. And I treat only the cyst with a recent increase in size or with mural nodule. This is only indication, and I follow the remaining cyst. Okay, so now we have some questions for Maria because we are with cystic neoplasm. So Maria, the first question is what I told you. Do you perform glucose only or glucose and CA? You answered previously that you perform both.
Yes, right. We perform both. Yes.
Okay. And the next question is about antibiotic prophylaxis. What do you do?
We used to do prophylaxis. Even, there are studies that now suggest that's not useful, but I prefer to do antibiotics before puncture.
Okay, so I think we have to say that for ESG recommendation guidelines, it is a weak recommendation, and with low quality evidence.
Yes.
But it's a recommendation. Another question about contrast enhancement. Do you do contrast enhancements in all the cases or in case of suspicious of mural nodules?
No, if I see something on the wall, a thickening of the wall, or of course something inside the cyst, I do contrast. Otherwise, if the cyst is completely anechoic and the wall is thin and regular, I do not need to perform contrast enhancement.
Okay. And finally,
there are other ways also to check for mural nodules, not only contrast, but also suction. During the suction, sometimes the mural nodules just disappear in your needle, and sometimes you can move the nodule with the needle. So contrast can be used, but if you have no contrast, you can also use other tricks to differentiate nodule from mucus that's mobile in the cyst.
Okay, and the last question for you, Maria, was what is for you the real place for confocal laser microendoscopy or biopsies through the needle compared to the fluid analysis?
The problem is that we really don't know now which is the place of these promising tools. I mean, in daily practice, if we think our daily practice, probably we do not need to perform these. I mean, if we speak about differential diagnosis of pancreatic cystic lesion, I think that now we really don't know which is the right place of these new tools. Probably if the results that are very promising will be validated by other groups because the authors are always the same, probably we can start to use in some cases.
Okay.
I don't know what do you think, Marc, but this is our practice.
I think yes. I think we have to be pragmatic, and we have no real scientific data comparing the place, the exact place between fluid analysis, laser confocal microendoscopy, and through the needle biopsy. I think there are lack of sensitivity of each tool for assessing pancreatic cystic neoplasm, but we do not know by putting together all these tools what we could achieve. Pierre, what do you think?
Well, we used CLE for a couple of years, but in fact, during a year, we had 5 or maybe 5, 6 cases where we really needed it. And it is most effective in serous cystic cystadenoma. But in fact, in serous cystadenoma, you have a normal glucose and a normal CA. So the diagnosis is quite easy to achieve with biochemistry, I think. So then the main problem, I think, are those cases where you hesitate between a pseudocyst and a mucinous tumor. And I think in those cases, both biopsies of the wall and CLE may be less accurate than just between serous and mucinous distinction.
Okay. I have just to say that I have the feeling that we have a better accuracy with CLA for serous cystadenoma, like you, and with biopsy through the needle for mucinous cystadenoma. This is my feeling, but this is not scientific, of course, but this is my feeling. So now we move to the pancreatic pseudocyst drainage, Pierre, and we had some question, multiple question about treatment of asymptomatic pancreatic pseudocyst. Of course, you were aware about that. You gave us at the end of your presentation the guidelines, which seems to be very clear, but we have some question about why doing that, because what is the outcome of asymptomatic pancreatic pseudocyst? So Pierre, could you clarify?
Yeah, we know there is a small risk of bleeding and infection in those lesions. I was interested, in fact, to read the guidelines, because in my practice, I usually don't treat pseudocysts that are 5-6 centimeters and that are asymptomatic. But if a pseudocyst increases slowly in size, and we see that in some patients with sometimes with ductal obstruction, especially in the tail of the pancreas, then I think it's a good indication. So it's not, I would not treat an asymptomatic pseudocyst that has been there with calcified wall. In fact, it's not so easy to drain when you have a calcified wall. But I would treat increasing in size cysts, even if they are asymptomatic, and also sometimes lesion in the head of the pancreas if they also increase in size. But then I would use a transpapillary approach. Okay,
and again, like for Maria, what about antibiotic prophylaxis?
Yes.
Pseudocyst drainage. In my center, we don't use antibiotics anymore when we puncture small cysts. I think antibiotic prophylaxis, when you drain a pseudocyst, I don't think that's of any interest, because the cyst is going to empty in the stomach. It really depends. I don't think that it should be routinely done. Okay. Because then you have to, if you want to treat with antibiotics, then you should give antibiotics until full resolution of the collection. Okay. That may take two months, so it's, I think, of no interest.
Okay. About your video case, which was very nice, you have 2 questions. The first one is about the use of confocal laser under microscopy in this case. Why did you do not do that?
Well, I never do that at first diagnosis. So as you understood, I punctured it first, and then we had a long discussion with the patient about future management. And of course, it could have been an option, but I'm not sure that in such a case, CLA would have been a good way to differentiate pseudocyst from mucinous neoplasm, because we know that mucinous neoplasms, they can bleed, so that can obscure the vision during CLE. Yeah. And also the wall is sometimes not complete along the mucinous. Sometimes you have ovarian stroma at some parts only of the wall. So CLE might be more complicated. I think more forceps would have been more effective, because then you could maybe biopsy several places and get more deep tissue.
Okay. The second question is about the very high level of lipase. How do you interpret the very high level of lipase?
It's in favor of pseudocysts, but you can see that sometimes in mucinous neoplasm also, and yes, in IPMN. So I think Yes, it's not discriminative enough. And I think in most series, lipase level is only of interest when it's very low and when you have low CEA, low lipase,
you are sure
normal
this is
glucose,
serious
then it's
cystadenoma.
serious cystadenoma.
Yeah, yeah. We have to say that even in mucinous cystadenoma, of course, we have no usual communication with the main pancreatic duct, but you can have an increased level of lipase in mucinous cystadenoma also.
Yeah.
Okay, so this is not discriminant. And I saw in your videos that you performed the pancreatic sphincterotomy of the accessory papilla. And so what is your goal? Because in fact, it was pancreatic cystic neoplasm. So you think at this time that it was a retentional cyst?
Well, in fact, the full story of the patient after distal pancreatectomy, she still developed pancreatitis. So I guess she had different causes for pancreatic pain, not only pancreativism, but maybe a genetic factor. And I think the mucinous lesion was found by chance, by chance, I think.
Okay, and the last question is about the indication for drainage of pancreatic pseudocyst or one with plastic stent or LAMS. So do you think we could say that plastic double pigtail stents are for pancreatic pseudocyst and LAMS are for one? But we have, of course, if you use LAMS to exchange quickly the LAMS at 1 month to decrease the rate of bleeding. Do you think we could apply these guidelines?
Yes, that's what we apply in practice. Although the definite time of LAMS placement is still discussed. Sometimes we remove it after 2 or 3 weeks if we finish the necrosectomy sessions. It really depends on each patient. And I think the risk of bleeding is much decreased if you place a double pigtail stent in the LAMS. The problem is mainly if you have disconnected pancreatic syndrome, then you have to take the LAMS quite quickly out or leave a plastic double pigtail stent in the LAMS. And sometimes you can remove the LAMS and leaving the plastic stent in place if it's long enough beside the pancreas.
Okay, so now
I agree.
Okay, you agree. So now we have no more questions. Just to say that in the Q&A box, we have a lot of congratulations for both of you for your presentation, which were very clear and very useful and very practical. So I want to thank Maria and Pierre for this very nice presentation. And I think we have a very good take-home message and very clear. So I think we could close this webinar. We have some slides just to remind you that we have in nearly 1.5 months ESG days in Praga, but it is a hybrid event, so you can be connected on the website. And the next is for registration. So don't forget to be registered with 1 full day of endoscopy and hands-on session and everything. And also to be part of ESG. Next slide, please. So don't forget ESG dual membership program. And you see now you have a decreased price of 150 euros instead of nearly 200 euros. So join us. And the last slide is for announcing the next webinar in 1 week, which will be very useful for publishing because it's a webinar dedicated to how to get your endoscopic research published. So, and it will be very practical and very useful. So thanks to all of you, thanks to the attendees, thanks to the experts, Maria and Pierre, and also to the webinar team, David, who worked a lot, and Gabi, who are still with us and helping us all the time. So thanks to both of you. So bye-bye.
Thank you. Bye-bye.
Bye-bye. Have a good lunch.
Thanks.
And see you in Praga.
Merci Marc.
Bye bye. Au revoir.
Bye bye.
Merci. Arrivederci.
Ciao.
Ciao.